This is the upper quarter screening examination. The purpose of this video is to demonstrate an upper quarter screening examination which we expect you to be proficient in and repeat throughout this internship. Dr. Bennett has provided an introductory video which describes the purpose and value in a regimented physical exam process. This screening examination progresses in a positional fashion from sitting to supine and prone. This screening examination is intended to clear regions of the body as origins or contributing factors. Keep in mind that some items may not be indicated during all examinations, such as neuromuscular screening examination on a patient without neurological symptoms, but that you should take every opportunity to practice the full screen anyway during the next few months until you have it committed to memory. Also, it does not include many resistance or special tests for certain structures in each region. These will be discussed in later modules throughout the CEN. The upper quarter screen begins in sitting. A neuromuscular screening examination may be performed if there is an indication that the patient has neurological symptoms or a likely radiculopathy. For the next couple months, practice this procedure with each of your patients during your upper quarter screen until you have it committed to memory. Expose as much of the patient's spine and upper extremities as possible for observation during screening. Begin with the Apley scratch test and fan fold tests for functional movement screening. Additional patient-specific functional screens will be identified during subjective examination. Then the patient is asked to perform all planes of cervical motion with overpressure. Spurling's A can be applied after overpressure and side bending to save time. The quadrant test, Spurling's B, loads the cervical facet joints and may reproduce pain or paresthesia. The cervical rotation lateral flexion test assesses upper rib cage mobility. Palpate with one hand over the first rib while you rotate away and side bend toward that rib. Next, assess thoracic flexion, extension, and rotation with overpressure. Rib cage mobility can also be assessed with inspiration and expiration. Assess shoulder flexion, abduction, and internal-external rotation with overpressure. In supine, assess OA mobility with craniocervical flexion and extension. Typically, OA extension is not a problem. Most patients will have difficulty with flexion. For this, the neck is rotated approximately 30 degrees and side bent slightly in the opposite direction. Then assess the cervical spine with AA mobility assessment by bringing the patient into full flexion to lock the lower cervical spine segments to focus motion at the AA joint. Be careful not to lose craniocervical flexion during this movement. Next, assess C2 through 7 mobility with side glides. If necessary, further assessment can be performed in flexion and extension. Finally, apply cervical distraction to assess for changes in upper extremity symptoms if applicable. When performing the ULTTA test, begin by blocking the patient's shoulder to avoid scapular elevation. External rotation may be further assessed as you test ULTTA by applying overpressure into full external rotation prior to neurodynamic testing. Next, externally rotate the patient's shoulder, then extend the wrist and hand, then extend the elbow. The test may be further sensitized by applying side bending to the cervical spine. Assess glenohumeral joint passive range of motion in supine as well, which allows you to further identify contributions to motion from each of the glenohumeral joint as well as scapular thoracic joints. AP and caudal glides should be performed for the shoulder as well. The AC and SC joints are assessed in supine as well. You may apply AP and caudal glides to the SC joint as you move into shoulder horizontal abduction and flexion respectively. You may apply AP and PA pressure to the AC joint. Next, assess elbow flexion with active range of motion, then overpress into flexion, then combined flexion, abduction, and supination, and flexion, adduction, and pronation. Supination and pronation will be tested with active range of motion and overpressure at approximately 90 degrees of elbow flexion. Then the patient actively extends their elbow and overpressure is applied into varus and valgus directions in addition to straight extension. Accessory motion of the elbow is tested next with humeral-ulnar distraction assessment in 70 degrees of elbow flexion. Proximal radial-ulnar AP and PA glides are tested in 30 degrees of elbow flexion, while humero-radial distraction assessment should be performed in 45 degrees of elbow flexion. Wrist and hand active range of motion is performed with overpressure, including flexion, extension, ulnar, and radial deviation. Then proximal and distal radiocarpal AP and PA mobility is assessed along with ulnar and radial glides. Next, distal radial ulnar joint AP and PA mobility is assessed in both pronation and supination. Then, individual carpal joint mobility is assessed. Finally, active range of motion and overpressure of the fingers and thumb are followed by accessory joint motion testing of the MCP and IP joints. In prone, assess cervical spine segmental mobility by taking up the slack of the soft tissues around the cervical spine and applying a posterior to anterior force through the spinous process at C2 through C7. In a similar fashion, you will take up soft tissue slack and move laterally onto the articular pillar, applying posterior to anterior force segmentally from C2 through C7. Finally, move on to the thoracic spine, applying central PA pressure from T1 through T5. Then move laterally to the articular pillars, applying segmental pressure to each level. Keep in mind that variations to this screen exist. Your clinical faculty will guide you further with these techniques. Also remember that components of this examination may be executed in a different order and to a different extent based on findings from the patient interview. That's the complete upper quarter screen. We will be monitoring your success with the upper quarter screen throughout your internship.